everyone, Dr. Campbell here, and today we're going to begin our journey into the evaluation and management section. So, when we get to this point in our Certified Professional Coder CPC program, it's sad for me because I know that this chapter is your next to last chapter, but this chapter is also very intimidating. It has a lot of things going on. And so, as I previously mentioned, we are going to have to unpack these concepts in more than one video. So, the first thing that I think is important for you to know is that effective January 1st, 2021, we had some changes that took place with one family of codes in the evaluation and management section. And in the future, we anticipate that there will be more changes to come to various categories of evaluation and management. Now, I probably have never said this before, but I'm going to forewarn you. You might want to go and grab some coffee, some tea, because it's going to take a little while to unpack what we're going to focus on today. And so I don't know about you, but I'm going to have my hot tea near me as I guide you through this section. So the first thing that I do want you to note at the very beginning of this section in your CPT manual, there's a table of contents. And the table of contents first identifies that there are guidelines for this section. And as you know, each section is preceded by guidelines. Immediately after that, you're going to go into the different code categories for evaluation and management coding. And for this particular video, we are not going to necessarily do any evaluation and management coding or even talk in detail about how we arrive at a code, because there are some foundational concepts that we have to go over first. So I want you to turn over to the green pages in your CPT manual. And this is where the guidelines begin for evaluation and management. So you know by now when I say the green pages, those are the pages that precede this section. So you know by now that evaluation and management codes are essentially the most commonly used codes, because before a provider can do a surgery, they have to first evaluate the patient. And so that's why these codes are up front. So the very first thing that I'm going to recommend that you do is sit down and read your guidelines. You may find that you need to read these guidelines twice because there are so many different moving pieces and parts that the first time that you read it, you may say, I don't know if I quite understand each and every concept. And that is normal. I will tell you that you will either love evaluation and management coding or you will hate it. I personally love it. I love it more than I like surgery, for example. And so you just have to allow yourself some time to lay that foundation of the concepts. So why do we have to read these guidelines? Well, number one, they give us some important concepts that we need to know when we're actually using the code. So for example, if you turn over into the guidelines, there is an area that talks about the definition of what is a new patient or what is an established patient. And as we take our tour today of the evaluation and management section, you're going to see the words new or established used, and those terms and those definitions are going to be critical. Additionally, you're going to see discussed in the evaluation and management section guidelines things like components. And as we tour the evaluation and management section today, you're going to learn that some of our codes are based on components. And then also in this area, you're going to find that some of the codes have time as a driving factor or a critical component of that code. And so that's why reading this information is going to be very, very important. So we are actually going to jump past these guidelines. And again, please, please, please read these guidelines. So the first family of codes that I want to introduce you to start on page 18 in your 2021 CPT manual. And these codes are titled Office or Other Outpatient Services. These codes are preceded by subsection notes. So that's another set of guidelines. And guys, by now, those of you who are enrolled in my CPC program, you know the importance of those subsection notes. So we have the section guidelines, we have the subsection notes, and then also in this section, true to form, we're going to have parenthetical notes, okay? So here we start off with codes 99201 through 99215. And these are our codes for new patients and established patients. Now, these happen to be the codes that were revised for this particular year, and they were revised to reflect how we actually can assign an office visit code. Office visit codes are assigned based upon whether the provider wants to establish the code based on the total time that was provided for this service or the complexity of medical decision making. Now, remember I mentioned that the guidelines had some important concepts that you needed to be aware of. Well, total time, medical decision making are discussed in the guidelines. So the other thing I want you to know, if you look on page 19, 99211, this is a code that is for a nurse visit. This is typically going to be a situation where perhaps the patient is coming in just for a blood pressure check. Now, with this particular code, the provider, the billable provider, so that's the physician or the non-physician practitioner, they are in the office suite today, but they're not necessarily in the exam room for this service, but they are in the suite so that they are readily available. Because what if the patient's blood pressure is measured and the patient's blood pressure is sky high? That person needs to be there to react to that finding and determine what the next steps are going to be. All right, next up on page 20, we have our observation codes. Now, I want you to think of observation as a situation where the patient is not well enough for a full-blown admission to the hospital, but they're not well enough to go home. So they're not sick enough to be fully admitted to the hospital, but they're not well enough to go home. And an example could be a patient who's having some chest pains and they want to observe the patient to determine if that patient might have a heart attack, right? They don't want them to have a heart attack at home. So with the observation codes, you're going to note that the first code that you see is 99217. And you're going to continue to see me look down at my manual because while I do have a lot of these codes memorized, not all of them. So 99217 is specifically designed for when we're going to discharge the patient from observation status. And I should mention that when you look at like Medicare regulations, they call observation a status, okay? So 99217 says that the patient was discharged from observation care, all right? Immediately after that, you'll see in red initial observation care followed by new or established patient. And here, immediately following that, subsection notes, immediately following that are initial observation care. Now, when you see the word new or established, one of the things that you'll want to note is that the definitions that you see in the front of your guidelines don't always apply, even though they'll say the word new or established. And you'll see that as you begin to explore these codes. So when we look at the initial observation care codes, this is that initial encounter for that observation status. We have 3 codes to choose from, 99218 through 99220. Now, remember earlier I talked about in the guidelines, notice how I keep referring back to the guidelines, how they talked about, or how I mentioned that they talk about components. Well, if you look at codes 99218 to 99220, what you're going to see here are 3 bulleted items under each code. And you'll notice with 99218, it says a detailed or comprehensive history, a detailed or comprehensive exam. And then medical decision making is straightforward or low. What that means, in order to assign this particular family of codes, we have to know what are known as our key components, which are history, examination, and medical decision making. Now, we're not going to do any coding today because we really have to just get through the section itself, provide this orientation, and then we'll come back and actually code evaluation and management services and really talk about what that process looks like. All right, so then immediately after that, on page 22, you will see subsequent observation codes. Now, your subsequent observation codes, notice that they have 3 bulleted items underneath them as well. If you look at 99224, problem focus interval history, problem focus examination, and medical decision making that is straightforward or low. Now, before you say, well, how do we know what that actually means? If you read the guidelines, you will understand what those concepts indicate. Now, I do want you to notice something on page 22 as you look at 99224. As you look at 99224, I want you to notice that the code description says per day. So that's very important. This code can only be reported once per day. Additionally, notice it states which requires at least 2 of these 3 components. That is important because some codes state that in order to assign that code, you have to meet 2 out of 3 components. But if you go back over to page 21, you'll notice that those codes indicate that we only have to meet 3, or that we have to meet 3 components, all 3 components. So what you're going to see, if a code requires that components be met, it's either going to be all of them or 2 of the 3 components. Again, we are at the floor of evaluation and management coding, the very bare basics. Okay, let's continue. So next up, we're going to go on over to page 22 for initial hospital care services. What do we start off with? Subsection notes. Critical, guys. The day of your national exam is not the day to read your section guidelines, your subsection notes, or your parenthetical notes. You have to read and understand them now. Okay, so on page 23, you will see in red initial hospital care, followed by the word new or established again, subsection notes, and then codes 99221, 99222, and if you turn over the page, 99223. Now, while you're on page 23, I want you to notice that these codes have those three bullets, which again are your key components. And key components are history, examination, and medical decision making. When you read your guidelines, hint, hint, you will find that there are more than three components. These three are known as the key components for a service. All right, so I also want you to note per day again, which requires these three components. Now, why subsection notes are important again, I'm going to drill this to death. There are some important rules you need to know. For example, let's say that a patient was seen in the office and then that same doctor admitted the patient to the hospital today. Well, the subsection notes tells us that when a patient is admitted in the course of another encounter or site or service, that all of those services that were performed today are essentially rolled up into the evaluation and management service for this initial hospital care. But it has to be the same day, the same provider. So as you can see, and as you already know, documentation in the medical record plays a huge role in the process. All right, so then on over to page 24, we have subsequent hospital care codes starting with 99231. Again, you'll notice that we have our bulleted items listed there. And then you will also notice that these codes only require two of the three components. So one thing that you will notice, your initial visits or your new patient visits, if components are required, they generally require all three components specified in that code be met or exceeded. But when we are talking about subsequent care or established services, those patients only have to meet two out of the three components. All right, next up, I want you to look on the bottom right-hand corner of page 24. There's something that's often very confusing, so I want to make sure I clear this up. Bottom right-hand corner of page 24 says observation or inpatient care services, including hospital admission and discharge. Now, I know you're thinking, wait a minute, didn't we just see some codes that kind of look like this? Kind of, sort of. These codes here say that your patient was a full admit to the hospital or observation, and they were admitted and discharged on the same calendar date. Okay. These codes here, which are on page 25, notice they're based on those key components. Because this is the initial and only service provided today, notice that all three components are met. When we're using these codes, we would not utilize, for example, the 99217 that we saw earlier, which is discharge from observation care, because these codes here include the admission and the discharge in one code. On the bottom of page 25, you will see discharge services for hospital inpatient services. So you should notice discharge has its own, or observation has its own discharge code. Hospital services has its own discharge code. Now, what I do want you to notice, of course, those subsection notes, and in this video, I cannot possibly cover every word on every page, but I know that you know now the importance of reading all of these notes. So 99238, what I want you to notice is that this is for 30 minutes or less. And then 99239 is for more than 30 minutes. So if in the real world the provider doesn't state the number of minutes that they spent discharging the patient and they meet all the other requirements for the discharge services, we would use the lowest code. We don't ever want to go to a higher code and get more money when the documentation doesn't support it. Of note, please note that we don't want to forget about the query process. This is when we can ask the provider a question about the services that were provided today to seek further clarification. And at your organization, once you start working, you'll learn what your process is for giving the query to the provider. All right. So next up, we're on page 26. On page 26, you see consultations. Now, consultations, one thing I want you to know immediately is that with consultations, Medicare no longer actually pays for these consultation codes. And there are some reasons why they stopped paying for them. You can Google it if you really care as to why they stopped paying for them. But years ago, they stopped paying for the consultation codes. The consultation codes begin with subsection notes. And then you'll notice the first family of codes is for an office consultation, which is on page 27. And you'll notice the components are listed here again. And in this particular area, notice you got about 5 office consultation codes. And then on page 28, you have your inpatient consultation codes. There are several rules that we have to apply when we want to report a consultation code. And so I'll just highlight a few. So we already know Medicare doesn't pay for these services. And in your textbook reading for this area, they talk about how we handle those situations. So I know that you're reading your textbook. But there's a couple of more things you need to know. Number one, a patient cannot schedule a visit for a second opinion and that be billed as a consultation. In order to code and bill a consultation, we have to have documented in the record what are known as the 3 R's, the letter R as in rhinoceros. So the first R is that there has to be a request for the service. That request can be oral or it can be in writing. And how do I know that? Subsection notes. All right. The second R is that the service has to be rendered. So the physician, the non-physician practitioner that's seeing the patient, they have to actually render the service and document it. The third R is going to be there has to be a written response. So let's pause for a second. The request for the consultation does not have to be in writing, but the response does. And with the response, what's going to happen is that the provider who rendered the service, they're going to send a report back to that requesting physician or non-physician practitioner and give them their consultative findings, their consultative report. And so usually they'll start off by saying, "Thank you for allowing me to see Mrs. Jones today. She's a pleasant woman who you sent to me for blah, 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 blah." Okay? So those are just a few rules regarding consultation, but not everything. Remember, in this video lecture, I'm covering the floor of what you need to know and not the ceiling. All right, so after the inpatient consultation codes, which are on page 28, and in case you're wondering, yes, these codes are all new patient codes, and they all require 3 key components. Now, I know you're probably thinking, well, what happens if they come back for a second consultation or a subsequent visit after the first consultation? Ha ha ha. guidelines give you that answer. All right, next up we have our emergency department codes, which are on page 29. And one thing that you will want to know about emergency department services is that the facility has to be open 24 hours. So, for example, here in Chicago, we have some urgent care facilities that close at like 8 o'clock. They cannot use emergency department codes. But then we have other urgent care facilities that are open 24 hours a day. All right, so that particular facility can bill out emergency department codes. Now, here on page 29, you will note that they mention new or established again, but everybody that comes to the emergency room, it's a new encounter. So the codes begin on page 29, the bottom right-hand corner. You'll notice, yes, key components, and all three components have to be met. The last code in the emergency department services is called Other Emergency Services, which is on the upper left-hand corner of page 31. And these are codes for physician or qualified healthcare professional direction of the EMS. So this is that two-way radio communication where our provider is at the hospital and they're providing direction to the ambulance folks via the two-way radio communication. All right, guys, we have critical care. And on page 31, you will see lots of rules and regulations regarding critical care services. Lots of rules and regulations here, okay? I don't want to scare you, but you see all those notes on page 31 and then page 32? Must read services. There are some requirements that have to be met for critical care services. Critical care does not necessarily mean that the patient is in a critical care unit. Critical care could be provided in an office setting based on the circumstances. Critical care codes are time-based codes. So on page 32, you will actually see a table that breaks down our two critical care codes, 99291 and 99292. You will also note on page 32, it is noted that if critical care is less than 30 minutes, you cannot report the critical care service. All right. Other things that you will learn when you read the subsection notes, that there are some services that are included in critical care and are not coded separately, and just some other things that, again, you need to know. Those of you who are in my CPC program, remember for your CPC exam, you're coding for the provider. So as we wrap up our journey together, just remember that you're coding for the provider and not for the facility. Now, once you get certified and you get your job, you may be coding for the facility, but the test that I am preparing you for is for the CPC, and you're coding for the provider. All right, next up on page 33, we have our nursing facility services. And true to form, they start off with some subsection notes, followed by, in red, initial nursing facility services, followed by your favorite words, new or established. On page 34, you will see three codes for the initial nursing facility services. They require the key components. They require all three key components, followed by 4 subsequent nursing facility services, and they, of course, require 2 of the 3 components be met. Now, you probably are saying, I really want to know more about this 2 of 3 and this 3 of 3. Slow down, grasshopper. Right now, you really want to focus on learning the code families and the rules that are listed here. All right, so page 35, upper right-hand corner, guess what? we have discharge codes for the nursing facility. So let's pause. We had discharge service codes for the observation care. We have discharge codes for hospital services. We have discharge codes for the nursing facility. And don't forget, we had that little family of codes if the patient was admitted and discharged on the same day from the hospital, inpatient or observation status. We're going to use that one code that includes the admission and the discharge. We're not going to be coding these codes separately. All right, the last code that you're going to see on page 35 is a code for an annual nursing facility assessment, and we have wrapped up nursing facility services. All right, next up, we're going to go on over to page 36. And on page 36, we see codes for domiciliary, rest home, or custodial care services. This is a concept that most people are not familiar with, but this is when a patient resides in a facility that does not have a medical component. And because it doesn't have a medical component, sometimes the provider goes to that home and actually sees the patient. It could be a group home for special needs patients. So codes that we have here, subsection notes, of course, also new followed by established codes. The new codes require that all three components be met or exceeded, and the established patient codes require that two of the three codes be met or exceeded. Now, immediately after that, we have domiciliary rest home or assisted living or home care plan oversight services. And those are in the upper left-hand corner of page 38, codes 99339 and 99340. You will notice that these are time-based codes reported based upon the time spent within a calendar month, either 15 to 29 minutes or 30 minutes or more. There are parenthetical notes all throughout the evaluation and management section, just like the rest of the sections, and so you want to watch out for those. On national exams, guess what, guys? They're looking to see if you've read these notes, if you can apply them given a particular scenario. So just watch out. All right, immediately after that, we have codes for home services. And on page 38, something that's important to note, home could be a private residence or it could be a hotel. And so, or it could be a cruise ship. Back when that was a thing, right? So right now, we're not cruising. That's one of my favorite things to do. And I actually saw a doctor on the cruise ship. One time I had gotten sick with like some heartburn or something. I thought I was having a heart attack, but it was heartburn from greasy food. All right. So for these home services codes, you'll notice new patient, established patient, 3 out of 3 components have to be met. And when I say 3 out of 3, that's because it says requires these 3 components. So that's 3 out of 3 because there's only 3 bullets: history, exam, medical decision making. Immediately after that, we have our established patient codes for home visits and the same setup. All right, guys, we're almost towards the end of the evaluation and management section. So next up on page 40, we have our prolonged services codes. Now, these codes start with subsection notes on page 40. And the first family of codes that you will see are for prolonged services with direct patient contact, except office or other outpatient services. Reason for that is we have another code that is used for that, and so pay close attention. So subsection notes, a table, just like critical care. And you'll notice that these add-on codes, a fair amount of them are actually add-on codes, and you should know by now, add-on codes cannot be used alone. they should be used in conjunction with that primary service. So your first two codes, 99354 and 99355, are for your outpatient settings, minus office or other outpatient services. Then on page 41, you have 99356 and 99357. This is for inpatient or observation prolonged services. Immediately after that, you have prolonged services without direct patient contact, 99358 and 99359. Those are time-based codes as well, with the first code being the first hour, the second code being each additional hour. There is a table on the upper left-hand corner of page 42. And on page 42, we have our next set of prolonged services codes, which are prolonged clinical staff services with physician or other qualified healthcare professional supervision. These codes are add-on codes as well, 99415, 99416, time-based codes, first hour, and then each additional hour. Page 43. Prolonged services with or without direct patient contact on the date of an office or other outpatient services. So now you see why we couldn't use those first codes with the office visits, because we have this code here, 99417. But 99417 has specific requirements that have to be met. Number one, they can only be used with the highest level new patient code, which is 99205, or the highest level established patient code, which is 99215. Cannot use them with that. Also, what you will notice, there is a table here that will help you plug in the time that was spent in order to capture the correct code. On page 44 in the upper left-hand corner, we have our standby services. Stand by me. All right, so these codes require prolonged attendance. This is when the provider is standing by for prolonged attendance each 30 minutes of service. Now, there are some stipulations regarding the use of this code. Number one, they talk about how they're providing standby for another provider. So they call them up or page them and say, we need you to be on standby for this particular patient for this particular situation. You'll read the rest of the notes for that, because I want to try to get done within an hour. All right. So next up, page 44, we have our case management services. First up, we have our medical team conferences. And what do we start off with? Subsection notes and a table on page 45, which is not related to case management. It happens to be a table that compares the different prolonged services codes. The table was so big, they couldn't put it over on page 42 and 43, so it's sitting over there. Again, I must stress the importance of learning your manuals now, because on the day of the test is not the first time for you to run into a code family and you're like, oh, I got to sit here and read it. You don't have time to do that during the national exam because that clock is ticking. So you need to read ahead of time. So, Medical Team Conference 99366. This is with an interdisciplinary team. And notice it states face-to-face with the patient or family, 30 minutes or more, participation by non-physician qualified healthcare professional. Non-physician qualified healthcare professional. Then, when you turn over to page 46, we have two medical team conferences codes without direct contact with the patient or family. But look at the description of these codes. Participation by the physician, 99367, 99368, participation by non-physician qualified healthcare professional. Now, way back when in chapter 1, we actually learned that a provider could be a physician, MD or DO, or it could be a certified registered nurse anesthetist, or it could be a nurse practitioner or a physician assistant. And so that's why they say non-physician practitioner. All right, so on page 46, we have codes for care plan oversight services and what you'll want to note here. First two codes, 99374, 99375. This is for home health agency services. 99377, 99378, hospice services. 99379, 99380, nursing facility services. In my manual, I actually have those words highlighted in those 3 codes. So when I go to this page, they pop out for me and let me know, caution, know where your patient is being seen. All right, next up on page 47, we have the beginning of our preventative medicine services. And of course, true to form, subsection notes. Now you guys see why I had to break this up, because it's so much to unpack by just looking at the code families. That's not going to take into consideration the time that you're going to spend actually looking at the actual codes and guidelines and all of that. So first up, we have new patient preventative medicine codes. What you'll want to notice is that in addition to these being new patient, these codes are divided based upon the age of that patient. When you turn over to page 48, we have codes for established patients, and they are divided by age. There are some rules in the subsection notes that you will want to review, because sometimes we have a preventative medicine service where the doctor or nurse practitioner identifies an abnormality that is worked up that may require you to use one of the initial office visit codes up front, but there are some specific rules that have to apply, but you need to read the rules first. All right, immediately after that, on page 48, lower left-hand corner, we have counseling risk factor reduction and behavior change intervention, and that's exactly like it sounds. So first up, we have individual counseling codes 99401 through 99404. These are time-based codes, followed by behavior change intervention. Individual, again, 99406 through 99409, time-based codes. And then we have preventative medicine counseling in a group setting. All right, immediately after that, we have our non-face-to-face services. And the pandemic has shown us that some conditions can be treated in a non-face-to-face setting. So on page 49, you will first see that we have our telephone services codes, 99441, carrying over to page 50, 99442, and 99443. Notes to take important note of, however, if there are some specific rules in place by the federal government, such as what we are experiencing during the public health emergency, some of the rules that you see listed here we may be exempt from following those rules during the pandemic. However, each and every insurance company is different, and you always want to follow their rules. For purposes of the exam, follow the rules that are in your coding manual. Immediately after that, on page 50, we have online digital evaluation and management services, subsection notes again. Page 51, we have interpersonal telephone, internet, EHR, consultations. Immediately following that, you have the codes on page 52. You will notice that these are time-based codes with specific descriptor and requirements that have to be met. On page 52, upper right-hand corner, digitally stored data services, remote physiologic monitoring. So this diagram that you see here is an example of this remote physiologic monitoring. On page 53, you'll see the codes for these services and another section that's called Remote Physiologic Monitoring Treatment Management Services. Isn't it amazing how one word can just change the code assignment? Read your subsection notes. All right, next up on page 54, under Special Evaluation and Management Services, we have codes for life or disability services. These codes are also available for work-related or medical evaluation disability services. 99450 is for basic life and or disability examination, whereas 99455 and 99456 are work-related or medical disability examination. What you will notice is that one code is specifying that the treating physician is also doing this examination, and then the other code says that this service is being provided by other than the treating physician. So sometimes, like for example, for disability, the insurance company may require that someone separate from the treating provider perform that evaluation because they want to confirm that this condition is actually true. All right. Next up, on page 54, bottom right-hand corner, we have our newborn care services. And what you will note here on page 55, we start off with code 99460. This is that initial service of that infant per day. 99461. This is also initial care per day. Well, what's the difference? Notice the end of code 99461, seen in other than hospital or birthing center. 99462, subsequent hospital care per day. 99463, initial hospital or birthing center care per day. Watch this. Patient is admitted and discharged on the same day. Immediately after that, we have delivery, birthing, room attendance, and resuscitation services, 99464 and 99465. Take a look at the differentiating factors for those two codes. And we're going to move right on to inpatient, neonatal intensive care services, and pediatric and neonatal critical care services. So I know you're probably thinking, wait a minute, didn't we just learn about critical care? Yes, but these have specific age requirements. All right, so we start off with subsection notes on page 55 and more subsection notes on page 56, followed by 4 codes. First up, we have critical care face-to-face services during an interfacility transport of a critically ill or critically injured pediatric patient. Watch this. 24 months of age or younger, time-based codes. Immediately following that, 99485, supervision of a control physician of interfacility transport for a critically ill patient, 24 months or younger, including two-way communication. Remember that word from previously? All right, immediately after that, we have inpatient, neonatal, and pediatric critical care services. Subsection notes, for days and days, page 57, 58. And then we have the codes on the upper left-hand corner of page 59. Immediately after that, we have initial and continuing intensive care services, subsection notes with the codes on page 60. Must read. All right, so we already talked about the critical care transplant, so I'm going to continue to move ahead. And next up, on page 60, we have cognitive assessment and care plan services. Now, when you look at these look at this code on page 60, you'll actually notice that this code is for assessment of and care planning for a patient with a cognitive impairment requiring an independent historian. You'll actually see that word in the guidelines when you read the guidelines. Independent historian in the office, home, or domiciliary or rest home with all of the following required elements. And it's all of those bulleted items that you see listed on page 60 and then the top of page 61. Immediately after that, we have our care management services. And our care management services are really focusing on chronic diseases. So on page 60, more subsection notes. Then on page 62, the bottom right-hand corner, you see chronic care management services. And then the chronic care management services subsection notes are followed by 99490 and 99439. Notice that this is for chronic care management with the following required elements. 2 or more chronic conditions expected to last at least 12 months or until the death of the patient. The chronic conditions place the patient at significant risk for decline. And then a comprehensive care plan is established, implemented, revised, or monitored. Then we have code 99491. This is where the chronic care management services are personally provided by a physician or other qualified healthcare professional. Immediately after that, we have our complex chronic care management. Now, you're probably thinking, those two kind of sound the same. There are some differences, and that's why those subsection notes are important. On to page 64. All right, so on page 64, we have a table for our complex chronic care management services. If it's less than 60 minutes, we do not report this service. And then we actually have 2 families of codes here, or 2 options, I should say. So here, complex chronic care management services with the following required components. Look at this. 2 or more chronic conditions expected to last 12 months or more, or until the death of the patient. Chronic conditions that place the patient at significant risk. Comprehensive care plan, established, implemented, revised, or monitored. Sounds the same, right? Moderate or high complexity decision making. First 60 minutes of clinical staff time, directed by a physician. All right, so then, guys, after that, we have psychiatric collaborative care management services, which start on page 65. And I know you're thinking, I know what she's going to say, so I'm not going to say it, but you know what I'm going to say, right? You know what I'm going to say about page 65. So these particular codes are on page 66, and they are divided based upon if this is the initial psychiatric collaborative care management or the subsequent psychiatric collaborative care management. Notice that third code of 99494 is actually an add-on code for each additional 30 minutes of the initial service or the subsequent service. All right, after that, we have on page 67 our TCM codes, or our Transitional Care Management Services. And this is where a patient is being transitioned from hospital to another site of service. And the goal is to ensure that the transition is smooth, the patient gets the care that they need, they understand all of the things that's going to go into transitioning that patient and keeping them, cared for so that they don't have to come back to that facility. All right, so the codes are on page 68, and they are divided by face-to-face within 14 calendar days of the discharge, face-to-face within the 7 calendar days of discharge. And you'll notice there are some other requirements that I'm going to know that you're going to read. All right, after that, we have our advanced care planning codes, 99497 and 98. These codes are time-based codes, and I do hope that you are seeing all of these notes in parentheses, because when they write exam questions, one of the things that they do is take a note and turn it into a question to see if you are realizing that that particular rule applies. So like, do not do this, or these codes may be reported separately if. All right, immediately after that, we have our general behavioral health integration uh, care management code, which is 99484. And this particular code requires at least 20 minutes of clinical staff time. And then those bulleted items, and it's per month, those bulleted items tell you what's required for this particular code. Well, guys, guess what? We have literally made it back to the beginning of the evaluation, or made it to the end of the evaluation and management section. But this was just the beginning. What are your next steps? You want to read read your textbook chapter on evaluation and management coding, which is chapter 19 for those of you who are in my CPC program. If you're in a different program, your evaluation and management may be in another chapter. You want to read your subsection notes throughout the entire section, and you want to read your guidelines that are preceding the chapter. That's really where you want to start. So in our class, we're going to do some hands-on evaluation and management coding just for you to understand these concepts at the most basic level. And then after that, I'm going to come back with part 2 of this. And part 2 of this is going to be looking at what happens in situations where we have to do the history, the exam, and the medical decision making in order to assign a code. And that's a whole nother level, guys. I'll see you real soon.